Mm. Well, I think we'll get away. We've just get underway. We've just hit the start time. So welcome and thank you for joining this International Haemovigilance Network webinar on the theme of donor vigilance. My name is Simon Benton. I'm the chair of the IHN Seminar Committee based in Sydney. I'm also joined by Dr. Shruti Narayan, Shop Medical Director and the President of IHN. Before going any further, as is customary here in Australia, I would like to give a brief acknowledgement of country. And in doing so, I recognise that I'm chairing this webinar from the country of the Darug people of Western Sydney. I pay my respects to elders past and present and celebrate the diversity of Aboriginal and Torres Strait Islander people and their cultures and connections to the land and waters of Australia. I also recognise the traditional owners of the lands where you are today and the First Nations people present in this webinar. Some brief housekeeping. The session is being recorded and will be uploaded to the IHN webinar, so the IHN website in due course. So keep an eye out for that. During the talks, you'll be muted with the camera off. We are looking at having questions at the end of the session after the 3 talks, but please type your questions into the Q&A box, which you'll see at the bottom of the screen, and we will monitor this and maybe, if possible, answer them along the way, or we'll save any that need the speakers at the end. And today's webinar is in recognition of World Blood Donor Day, which, of course, as I'm sure you know, is on June the 14th, the birth of Karl Landsteiner. And so if I could have the next slide, please. The QR code will take you to the WHO website for World Blood Donor Day. And the theme this year is Give Blood, Give Hope, Together we Save Lives. So Shruti, next slide, please. So World Blood Donor Day is a global tribute to the millions of voluntary blood donors, voluntary and unpaid blood donors who give others a second chance at life. Their generosity saves lives, strengthens communities, and embodies the spirit of solidarity. It's a day to say thank you, but also to spotlight the ongoing urgent need for safe, regular blood donations. This year, we honour the hope, the kind you give with every drop of blood. And because millions of patients around the world rely on blood transfusions every year, hope flows through every donation. Next slide, please. Oh, next slide, please. Thank you. So this on the screen is a brief outline of the webinar. So I'm introducing, Shruti will join us shortly. 3 speakers, questions at the end, we've got time, and a brief poll at the end to elicit some feedback from you as to how things have gone. So thank you, Shruti. It's now time for you to give us a welcome from the IHN board.
Yeah, thanks very much, Simon. And it is a warm welcome again on behalf of the IHN board and everybody at IHN to all those who are attending. This is a global one, so I think, please, thank you. And let's again collectively thank all our blood donors. No transfusion can happen without the donations from our blood donors. And to commemorate that, as Simon has said, that this webinar we have brought together key expert panelists, and who can then be sharing their insights on donor adverse events and also how we can actually optimize donor safety as well. And I really appreciate, and a big thank you to Joe as well, who is joining us for the Q&A. And on behalf of IHN, there is also an exciting announcement that I wanted to actually share on the slide. So we have just released an app for the International Haemovigilance Network. So if you can actually then go to your, whether it is Apple or the Google Play, this is actually a free app to download. And if you can just search for IHN, it should come up as the International Hemovigilance Network. And it is free to download. And what this essentially gives you is actually a ready access, to all the resources on the IHN website. And we will be working hard to actually then signpost all the various hemovigilance reports from around the world, all the recent publications as well, and also the recordings from the from such webinars such as these. So you'll have that instant access, and please do share this widely, and also provide us your feedback as well. So I'll just pause for a couple more seconds so that you can actually scan the QR code, and that will take you towards downloading the application as well. Okay, and I would also like to take this moment to indicate that there is the SHOT Symposium that is happening on the 11th of July at the Hilton Birmingham Metropole Hotel, and there is still time to actually register. So please join us again for the highlights of the annual SHOT report, and also various other transfusion safety as well as hemovigilance related topics as well. And we would also be announcing about the 2026 IHN Symposium in a couple of months' time. So watch this space. So without taking too much time, so I think over to Simon to introduce our first speaker, Imad. Again, enjoy the webinar.
Brilliant. Thanks very much, Ruthie. And again, thanks to everyone for joining, and thanks to our speakers for giving up their time to join with us. And our first speaker is Dr. Imad Sandid. Imad is a postgraduate specialist in medical biology covering bacteriology, virology, parasitology, hematology, immunology, and biochemistry. He has more than 35 years of experience in transfusion medicine and blood components, and his expertise has led him to participating and managing both European and national network programs, along with representation on various national and international blood-related committees. The subject of Imad's presentation is cardiac serious adverse events in blood donors. Over to you, Imad.
Thank you, Simon. I thank the organizers for giving me the opportunity to present the French study on cardiac adverse events. I can share my screen. Yeah. No. Yeah. Okay, this is a retrospective descriptive study of hemovigilance data on cardiac serious adverse events occurring after whole blood or apheresis donation and reported during the period 2010 and 2021. I will first briefly and broadly present the context that led us to carry out this study, and I will then present our data analysis methods, results, and conclusion and next steps. For the internationally recognized classification and definition of donation-related complication include heterogeneous complication under the term of major cardiovascular events or other severe complications like myocardial infarction, cardiac arrest, and other acute heart symptoms, stroke, or death within 24 hours of donation. Yeah. To our knowledge, there is no public scientific evidence regarding a possible causality of the cardiac serious adverse reactions observed in blood donors and blood donation. For donor safety, given the severity of the cardiac SAR, and for a prevention perspective, it's important to identify the cardiovascular risk factors that could be detected in the donor selection process and of prospective donors. And finally, this cardiac SAR reports ask question about the involvement of the donation, about the time limit to be considered in this type of event, about the evaluation of the imputability of a post-donation major cardiovascular event in the presence of the other causes pre-existing the donation, like arteriomatous vascular lesion. Yeah. This is the figure. This figure shows the major cardiovascular events reports reported to the European Union for the period 2018 and 2022. These reports are not exhaustive, given that reporting is in voluntary mode, that only a few member states report them, and that there is no common approach for assessing of the causality and imputability. This shows that the number of MCE is higher in whole blood than in apheresis donation. In contrast, the incidence of the MCE per 100,000 donations is higher in apheresis than in whole blood, because apheresis represent in the EU 20 to 25% of the total numbers of donation. The aims of the study is to improve the description of these events by analyzing the cardiac SARS reported in France, identify risk factors likely to be detected in these donors at the pre-donation interview, and in the field of the hemovigilance practices, verify the feasibility of implementation of diagnostic criteria and additional criteria at the current levels of imputability for the reported cardiac SAR. Retrospective, the study, descriptive study of 125 cardiac SARS of severity grade 2 to 4. This is a grade serious adverse reaction at the national scale from moderate to death, reported in the French National Hemovigilance System between the 1st of January 2010 and 31st December 2021. Each report was first analyzed individually and independently by each one of the 5 experts of the expert panel. Then their collegial analysis made it possible to discuss each one and reach a consensus for all the parameter studies. Among the expert panel, 2 are anesthesists, 1 cardiologist, and the 5 experts have expertise in the field of donor hemovigilance. The diagnoses retained are those established by medical reports and, where applicable, hospitalization reports collected in hemovigilance surveys. The current definitions of coronary accident diagnosis have been refined in recent European recommendations, and the non-inclusion criteria were insufficient data to establish a diagnosis, invalidate diagnosis of cardiac SAR, absence of donation. A temporal criteria was added to this criteria, extended to 48 hours, the cutoff beyond which a cardiac SAR is no longer considered potentially linked to the donation. the absence of donation concerns MCE incorrectly reported because the MCE occurred before the donation and the donor was not taken for this reason. Usually, the cutoff is 24 hours, but the kinetics of troponins, a highly specific biological marker of myocardial damage, shows that can rise up to 48 hours after the onset of symptoms. On this basis, with the consensus of all experts, we retain the 48 hours after donation, and after 48 hours, the reports were excluded from the study. The following parameters were studied for each report and each donor: diagnosis, onset time, imputability, severity grade, type of donation, and age, gender, and cardiovascular risk factors of donors. The study on the imputability levels showed a difficulty in applying them for donors with pre-existing coronary arterial lesion before donation. In fact, these lesions not detected during the pre-donation interview constitute convincing elements which make it possible to attribute the adverse events or reactions to causes other than the donation, which will lead to exclude the imputability of the donation. This is the why we introduce the notion of aggravating or triggering roles of donation in the occurrence of cardiac serious adverse reaction. In the cardiac SAR, if the cardiac SAR occurred between 24 and 48 hours after donation, this is defined as a role aggravating and triggering one. The donation is considered possibly aggravated or triggered the adverse events. If it occurred between 12 and 24 hours, this is defined as 82, probably. And if occurred within 12 hours, this is defined as 83. The donation is considered certainly aggravated or triggered the adverse events. The cardiovascular risk factors considered in the studies were those defined at the national level and incorporating the recommended in Europe in this field. First, the age and gender of donor, a family history of cardiovascular disease, smoking, diabetes, hypertension, dyslipidemia, obesity or overweight, and a personal history of cardiovascular pathology pre-existing the donation was added to the cardiovascular risk factors assessed. Sedentary life and microalbuminuria were not taken into account in our study. In our the hemovigilance database, we initially identified 125 reports distributed as follows, according to whether or not a cardiologist opinion was provided. For 78%, we included the advice of the cardiologist. 20 17% included the advice of an external medical advice, but not cardiologist, and the 5% did not obtain any medical advice. The distribution of the 125 reports, when applied the study's inclusion criteria among the 125 reports, the majority 75 reports 75 reports were included in the study and divided in 58 coronary accident and 17 arrhythmia. The other 50 were excluded for different reasons previously presented. The distribution, the incidence per million donation was 2.1 of whole blood donation and 5.3 for apheresis donation, mainly for coronary accident and myocardial infarction. The distribution of the gender, the men, women ratio observed for cardiac serious adverse reaction indicated a clear man predominance, and the median age of 55 years for men and 47 years for women is significantly, the median age is significantly higher than the median age of the total all donors for the period 2010 and 2021. This is respectively 46 year for men and 41 year for women. The distribution of donors with the cardiac serious adverse reaction studied about the reported CSAR by age groups shows clearly that 69% of reported CSAR concerned donors over 65 and 89% of donors over 40 years old. The cardiac SARS of grade 3 occurred in majority 69 cases and grade 2 in 1 case. The severity of arrhythmia was less than that of coronary accidents. We didn't observe any death and hospitalization in 5 cases versus 53 cases in coronary accidents. Among the cardiac SARS, we recorded 5 deaths, 4 with myocardial infarctions after whole blood donation, and 1 acute coronary syndrome after plasmapheresis, but we have a different period of occurrence between 9 hours after donation to 2 days after donations. The analysis of cardiac SAR based on the time to onset, shows that 56% are identified as donation possibly aggravating the SAR, 24% probably aggravating, and 20% certainly aggravating. Therefore, approximately 80% occur within 24 hours and probably or certainly aggravating the SAR. Thus, the donation was assessed as an aggravating or triggering in factors for a high level of SAR. And among the cases classified 83, certain, the serious event started before the donation without being detected at the pre-donation interview in 6 cases. And in 5 cases, it was anginal pain between 2 days and 4 months preceding the donation. In 1 case, it was a pre-existing arrhythmia. The distribution of cardiovascular risk factor that reported is clearly the age in 68%, the body mass index 60%, smoking 44%, dyslipidemia 29%, hypertension 23%, family history of cardiovascular disease 21%, and diabetes and pre-donation cardiovascular pathology in 5 and 4%. In 8% of reported cases, no cardiovascular risk factor was identified. There were 5 reports of arrhythmia and 1 report of coronary accident. Among the 58 cardiac serious adverse reaction of type coronary accident, the 7 had at least 1 cardiovascular risk factor. 50 cases had at least 2 risk factors. 38 cases with at least 3 CVRR, and 20 cases had at least 4 cardiovascular risk factors, and 5 cases had 5 cardiovascular risk factor. In these 5 cases, which started before the donation, without being screening at the donor pre-donation interview, the donors had 2 or 3 cardiovascular risk factors, and in the 17 arrhythmia type cardiac SARS, only 4 had 3 cardiovascular risk factors, and none had 4 or 5. For the conclusion, this large retrospective study provides more complete knowledge of cardiac serious adverse reaction likely to complicate donation of blood and blood components, knowledge that has until now been very fragmentary for coronary accident. For each of the 2 nosological entities concerned, the coronary accident and the arrhythmia, it made it possible to specify the pathologies observed and the characteristics of the donor concerned. The main findings of this study are as follows. The estimate cumulative incidence of cardiac SAR is 2.1 per million donation. It was significantly higher for apheresis donation than whole blood donation. The gender distribution is highly different from that of the standard population of over the same period of donors. The median age for males and it's 55 years for men and 47 years for women were significantly higher than those standard donor population. In addition to age and gender, other risk factors were identified among these donors, like obesity, smoking, hypertension, dyslipidemia, and diabetes. And the incidences observed for coronary accidents and arrhythmia was respectively 1.65 and 0.48 per million donations, confirm that these are fortunately very rare serious adverse reactions in donors. The severity is different between SARS of the type of coronary accident and those of the arrhythmia type. The first are all severe, leading the donor either to hospitalization in 91% and death in 9%. Arrhythmia type serious adverse reactions are significantly less severe, with no need hospitalization in the majority of cases and no death in this group. Given the severity of cardiac SAR of coronary accidents, these observations led to reflect on the possibility of reducing their incidence by specifying the donor selection criteria of prospective donors regarding cardiovascular risk factors. Based on this, the observation of our study on cardiovascular risk factors, it seems relevant to suggest that any prospective donor with an cardiovascular risk factors, most often age and gender, actively seek, within the framework of the donor pre-donation interview, the 6 other cardiovascular risk factors considered in this study and recent clinical signs of coronary arterial disease. From this information, the donor selection criteria for cardiovascular risk factor, when a prospective donor has more than 3 cardiovascular risk factors, or recent suggestive clinical signs, could be a permanent deferral or a temporary deferral with return to donation subject to the opinion of the cardiologist. This should particularly apply to apheresis donation prospective donors who are more at risk than whole blood donations. And for the next step, a second study is ongoing at the ANSM about serious cardiovascular and neurovascular adverse events in blood donors, monitoring over the period 2011 and 2022, with the aims to compare the incidence rate of these adverse events in blood donors with the general population, and to determine the risk factors of the occurrence of these serious adverse reactions following a blood donation occurring within a maximum of 48 hours after donation. And to finish, many thanks to the expert panel and my colleagues of the ANSM hemovigilance team and the National Hemovigilance Network, especially to the EFS, the French National Blood Service. And you can see at the reference of the publication on this topic published in May 2025. I thank you for your attention. Thank you.
Fantastic. Thanks very much, Imad, for a fascinating talk on that interesting donor adverse event. Well, our second speaker is Dr. Veronica Holt. Veronica is a colleague of mine. She is a public health physician who has worked in blood safety and policy for the last 12 years at the Australian Red Cross Lifeblood. She works with the Donor and Product Safety Unit and has a focus on both assessing and minimizing the risks of infectious diseases posed to blood safety and monitoring and reducing donor safety risks. Veronica has an adjunct associate professor position at the University of Western Australia and has published peer-reviewed articles on both donor and product safety. The topic for Veronica's presentation today is donor adverse events and plasma donations. So over to you, Veronica.
Thanks very much, Simon, and thanks for inviting me to speak. So as Simon said, I'm speaking on plasmapheresis almost exclusively, mostly concentrating a bit on the short-term effects given Mary's next talk, but a bit about the longer term. And just acknowledgement, so this talk is based on two factors. So there was a publication done with my fellow authors listed there, which was a literature review. We wanted to do a systematic review, but the evidence just wasn't there. So acknowledging that and acknowledging Dr. Joe Spiddy, who works at Lifeblood, who does all our donor adverse event analysis and policy, and we work together. So a lot of the data that I'm presenting today from Lifeblood is from Joe. So just to give context, plasma collections are increasing, and in the past, recovered plasma was obtained from whole blood, and that was sufficient. But you can see on the left is our Lifeblood collections. Our whole blood collections are in red over time, and they went down, and now they're stabilising. It may be increasing a bit, but our plasma collections, from 2004 went from less than 200,000 to now, getting up to almost 1 million. And on the right-hand side, you can see from our National Blood Authority data, our grams of immunoglobulin issued in the last 10 years have gone up significantly. So it's basic. Oh, sorry, I meant to click myself off there because I'm covering the screen. But basically, to keep up with demand, we need to increase our plasma supply. Despite Australia increasing our donations quite significantly, our self-sufficiency has actually gone down a little bit because we just can't keep up with demand. So it's a big problem over the world. How do you get enough plasma to treat patients but do it safely for donors? So I really like this slide, which I got off Vox Sanguinis. It just shows the blood donor criteria and how complex they are when you really try and think about it. Now, recipient safety is first and foremost because blood establishments exist to provide recipients with safe and sufficient blood supply. But obviously, we are nothing without the gift of life from donors. So donor health and safety is of vital importance. But also underlaying those things are a lot of operational efficiency. We need to be able to implement these changes, easily, so donors are satisfied with the service they get, and it's not overly complex. So it's really it is quite complex to balance all these factors, whilst balancing, if you had no risk at all for donors, then you wouldn't have any blood. That's just a fact. So it's making it as low as reasonably achievable. So blood donation is low risk and most donors feel well, but donors can, and we've just seen before, experience medical adverse events while donating or after they attend, and they can sometimes be serious, but fortunately the serious ones are low incidence. Now, we call a complication related to blood donation a donor adverse event. Now, this is just our data in lifeblood from the financial year, and you can see that plasma sits in between whole blood and platelets. Now, I don't like to read too much into these figures because you've always got to adjust for age, donor experience, what the events are, but nonetheless, plasma's in between the two, which 4% experience some donor adverse event, but fortunately most are mild. So just going to talk briefly about venipuncture injuries in plasma donations. Now, obviously, when you're putting a needle in and a needle out, that occurs in all blood donations, but compared to whole blood, the procedure's longer and there are multiple draw and return cycles. So there's more opportunity for needle displacement. And when you look at kind of DAE data that's presented in the literature, because plasma donors tend to be more experienced, you can't really compare, and you look at our data and there's not too much difference. But we know when we compare first-time whole blood donors to first-time plasma donors, the rate of a venipuncture injury is about 3 times that of a whole blood donor. Fortunately, most are simply hematomas, which is mostly a mild donor adverse event, and then followed by painful arm, which is when none of the others apply. But none of the most serious is a nerve injury. Now, the rate of nerve injury, fortunately, is negligible. It's been reported as 1 in 2.37 million. Now, when in our data there, we include nerve injury and nerve irritation. Most of those are irritations that go away when the needle is taken out, or if there's a hematoma, they resolve within days. But it's approximately 6 times the rate in whole blood donors reported in the literature, but still very low. So vasovagal reactions in plasma donors. So donor inexperience is the largest risk factor for vasovagals, explaining why when you look at our rate, the whole blood donation rate seems higher. That's part of it anyway, but female and younger donors are at higher risk in general. Now, in terms of vasovagal contributors, there's a vasovagal reaction, a fear reaction in itself, plus volume loss is an important contributor. And to manage that, the COE guide includes a collection cap of 880 mils with anticoagulant, or 800 mils without anticoagulant, and volume limits shouldn't exceed 16% of total blood volume. Now, in Australia, we manage that with a tiered donation system with a nomogram. Most countries tend to have nomograms that kind of guide collection volume on donors' gender, height and weight. We go up 13% in women, then 16% with a cap of 750, then 800 mils for the third donation. Obesity decreases TBV per kilogram, so we have a BMI cap where you can't increase with that increased weight as well. And there's things in the donor centres that are known to decrease vasovagal reaction. So adequate hydration is really important with food. Now, applied muscle tension, there's evidence in whole blood donation. The evidence in plasmapheresis donations isn't as great, but it results in an immediate blood pressure increase. So it would be expected to work. So we advise it for both. We have hopefully a calm and welcoming environment. We recently introduced some quiet times in various donor centres. Some donors like that. And in Australia, we give post-donation saline, which especially we see in our data when for whatever reason, there's a needle incident and we can't give post-donation saline, the vasovagal reactions, especially delayed, do increase. So that whilst there's not good evidence for post-donation saline, when you actually look in the literature, it does work, in my opinion, but the great evidence isn't there. And just a little mention of upper age donors and vasovagal reactions, because you see in all the data that older donors tend to have lower rates of vasovagal reactions when you adjust for donor and experience. They're about 3 times lower. However, when you look at the data carefully, they have higher risk of serious vasovagals, including loss of consciousness, vasovagals occurring off-site and requiring outside medical care. So we don't have an age cap in Australia. So if someone's a repeat donor, they can donate whilst they're healthy enough. Our oldest donor is 93. But we have introduced some policies to try and protect our upper age donors a bit, in that we used to allow any repeat donor come back. Now we have a 5-year cap. So if they haven't donated in 5 years and they're over 80, that we no longer accept them. If they have a delayed vasovagal over 75, we permanently defer them, whereas younger donors, you take into account where they're precipitating factors, things like that. And we have some statements and information and encourage them to stay longer in our refreshment centre. Now, moving on to some apheresis-specific events. So citrate is used in plasmapheresis to prevent the blood from clotting while it's in the machine, so the cells can be returned back to the donors. How it works, it binds with free calcium and blocks the coagulation cascade. Now, some of the citrate is returned to the donors when cells returns. Generally in the plasma, that's where it goes. So that's why in platelet pheresis, the rate is generally higher. One of the reasons, and you can see there, is because we're keeping the plasma. Calcium also stabilizes nerve and muscle cells, so the decrease results in a citrate reaction, which is numbness and tingling of the lips. As a mild, and then it can progress to tetany, but we've never seen a case of that, because obviously you get alerted when donor has a citrate reaction, and we can usually prevent progression from stopping the donation if need be. But if it's a mild, usually just decreasing the speed of the return will make a mild citrate reaction go away. So in terms of citrate, are there any longer-term consequences? Because it has been shown that citrate decreases ionised calcium. It also increases parathyroid hormone in platelet donors, that's documented. We know that prophylactic calcium, there's not good data that in plasma donors specifically that it can prevent citrate reactions, but we give it because we figure it does increase the level of calcium in the body, but to be effective, given it takes probably a good hour to be absorbed, at least 30 minutes before the procedure. So decreasing that return rate. But bone, in terms of bone metabolism, the SCANDAT data, so the data in Sweden and Denmark, didn't show an association with apheresis donation and bone fractures. And also in terms that there hasn't been a significant reduction in bone mineral density, and that's in platelet donors, that they haven't been able to find that where there's more citrate load given back to the donors. So although there is limited research, given the lower citrate load in plasmapheresis, it's probably unlikely to be a significant issue. So infiltration in blood donors. Now in Australia, when you return cells or give saline at the end of donation back into the needle and it moves, it may go into the tissues, and that's known as infiltration. In Australia, any kind of, even a small hematoma that occurs during the return, we classify that as infiltration. So our rates of infiltration appear much higher than what I see in other international data. But it's really a classification. Now, the signs and symptoms are swelling or tightness of the skin, pain or discomfort. We always assess for impaired circulation, but really in terms of, the worry is that a compartment syndrome will be caused, but that's really a theoretical risk. So because donors are conscious and they will see if there's pain, most of our infiltration are low volume events. And if, fluid saline, for example, goes into the subcutaneous tissue, it's really, absorbed relatively quickly. So that is more of a theoretical risk than a true risk. And the only case report I can find of compartment syndrome due to intravenous fluids was someone having an operation who was unconscious and given, lots and lots of fluids. So not the same as blood donation. Hemolysis is another problem that until we changed our plasmapheresis platform, we hadn't ever had a case. Now, what hemolysis, damage to the donor red cells while they're in the machine, can result in released hemoglobin. Now, if that's given back to the donor, then they will have an increased hemoglobin that can cause, the most common symptom is pink urine. So we had 0 cases, then we changed our machine and we noticed we were getting cases. Now, we used to refer donors to hospital, but after we looked into it a bit more and thought, well, these are well donors. They're getting, a bit of hemoglobin that's been hemolyzed for some damaged red cells, but they're healthy. They'll be able to, pass and they'll get over it without any problem. There's no point sending them to hospital for a hemolysis screen because we know what the cause is. So now we just advise them to see their doctor if symptoms occur after 24 hours if they need to, or if they have significant pain, which they don't. And we've introduced some additional checks which have decreased our rates of hemolysis and making sure, if alarms go off, we're not returning the cells to the donors and we cease the collection. So in terms of other rare events, there is a risk, and it has occurred in the past, not in Australia that I know of return of blood that's clotted. Now that's happened if the wrong solution is used or insufficient anticoagulant is given. Now we have engineering controls where we can't put the saline up where the anticoagulant goes, just can't happen. So it's really a theoretical risk for us, but it can occur. Now, in terms of air embolism, in the past, when they had older plasma machines, I think some were under positive pressure, but you really need quite a bit of air to cause a significant air embolism. And with modern machines and alarms, that's unlikely to be a significant issue. Anaphylaxis, we get more anaphylaxis in the recovery area with refreshments rather than to an actual plasmapheresis, but it has happened, so it can occur due to, an ingredient or something used in the collection kits, but fortunately it's rare, and we have adrenaline that we give if that does occur, which is, I think we've had like 1 case in a year or maybe 2 in the last 2, something like that. And pulmonary embolus is another relatively rare. These are all less than 1 in 1 million generally, and obviously if a clot develops and it breaks off and travels to the lung, that can cause a PE. So just going to move on quickly to some of the kind of not longer term but other issues. So immunoglobulin is what we want from donors to manufacture IVIG and other products such as that. So it's the main driver. It is known that when you take plasma, you'll take the immunoglobulin and levels will drop acutely after a plasma donation. Now, the reference interval we have for immunoglobulin is 5 to 15, but as per the Council of Europe, if it falls below 6, we do not allow continued donation. If it's between 5 and 6, we give them a smaller wait period than if it drops below 5. Now, regular monitoring has shown to detect donors who fall below the reference interval. Now, you can see this data was recently published by Australians. We had over 200,000 immunoglobulin results from first-time donors and then followed them through. You can see that they generally don't fall too much. This is in our situation where the average donation frequency is about 5 times a year, and donors aren't allowed to donate more than 26 times a year. But the ones who are going to drop below that reference interval are generally the ones with very low hemoglobin to start with, and most people will stabilise, and the donors with a high immunoglobulin to start with have a very kind of low chance of falling below that reference interval. So it's really the low ones to begin with that are at risk. Now, iron and hemoglobin. So there's conflicting literature about plasma and does it drop your iron and hemoglobin? And that makes complete sense when you look at the differences between procedures. So if people are taking high volume samples for routine testing every time you take a plasma donor, if people are not giving post-donation saline, then there can be significant red cells left in the harness tubing that isn't washed back to patients. So those two factors can result in a significant loss of red cells, essentially, which can cause iron deficiency and anemia. But if you take into account, so the US plasma centres, some of them do testing from the plasma, so they're not taking those samples, and post-donation saline, so they're not leaving that blood in the harness. And you can see this is our kind of whole blood equivalents comparing our plasma platelets and whole blood donors. And you can see where we're actually going to implement rinse back for platelets because of this to decrease that whole blood equivalent loss in platelet donors. But you can see that plasma donors lose very little iron, and they'd lose even less if we didn't take that 11 mils for testing. And in the data, 20 depends completely what they're equivalent to a whole blood, depending on those factors. And just, I'll leave this in case Mary's talking about it, but there's a potential risk of malignancy, but it's never been proven apart from one associated study that there wasn't a clear dose response and confounding factor information. So there's no definitive evidence that it does, and other studies haven't found any evidence. So to conclude, low frequency plasmapheresis, and that's the other thing, there's no good definitions of what low and high is. People use different things, but there is low quality evidence, but in general, we have conservative criteria and it's low risk. Now, even higher frequency plasmapheresis, and this is quite a controversial statement, but I think with adequate monitoring appears low risk from the observational studies that some of the US plasma centres have published. It's not high quality, but and if you do monitor donors and you remove them if they have a low IgG or, test, make sure they're not becoming anemic, then to me, it is kind of a healthy donor effect, and the healthy donors continue to donate, but they're the ones that can tolerate. But most centres like Australia, with an average of 5, maximum of 26, we're not those high frequency donation centres. And you need to balance donor health with collection efficiency. Obviously, collection of long-term data, we need good kind of high quality studies, large linked database to really get that definitive evidence. So we have a lot of observational evidence, but we need to balance that supply and, whilst allowing donors to donate safely. And there's no reason, a lot of kind of female donors or lighter donors reach their kind of TBV, but in terms of larger male donors, they reach the cap before they reach their TBV. So there's no reason yet why you couldn't take more potentially off larger male donors, but you have to balance that with, we looked at that and the bags weren't big enough. So even though they're having less of their total blood volume taken than females, it's balancing all those factors. So that's it from me, and I'll stop sharing my screen.
Brilliant. Thanks very much, Veronica. Once again, another interesting talk on an interesting subject. Well, our final speaker today is Dr. Mary Townsend, who I believe has actually just recently retired from her role, particularly as Senior Medical Officer at Vigilance. But in introducing Mary, I could do no better than quote the America's Blood Centre's recognition of Mary for their 2025 Thomas F. Zook Lifetime Achievement Award. And in the website, they say that Dr. Townsend's career from Nocona, Texas, to leadership roles at ABC and AABB has significantly improved donor care practices and enhanced the safety of the national blood supply. Her journey through impressive academic achievements led to pivotal roles in shaping donor care practices. Dr. Townsend's contributions to the AABB task force and her work on donor biovigilance have not only improved the donor experience, but have also set new standards in the field. Her lifetime of dedication has touched countless lives, leaving an indelible mark on the transfusion medicine landscape. So I think with that, that is a perfect introduction to Mary's talk.
Hello, I'm Dr. Mary Townsend, and I want to thank you and thank the organizers for the opportunity to discuss this topic today. As you will see, these are the objectives. We're going to review relevant arm anatomy, describe serious needle adverse events, and provide rates for serious adverse events where available. As you can see, this is a picture of one of the needles that's used to collect blood, and as you can see, they're very big and they're very sharp. I want to talk about needle adverse events. With the possible exception of mild bruising or hematomas and mild allergic reactions, by far the most common class of donor adverse events is vasovagal reactions. But when looking at needle reactions, rates of serious needle reactions are very uncommon to rare, and that's because of the 16 to 18 gauge needle, which is very large. Also, we can't see through the skin, so this is blind entry, and there's inconsistent anatomy from donor to donor. This shows data from Vitalant, courtesy of Dr. Hanny Camel, showing the rates of adverse events for 6 years. The magnitude of the adverse events compared with other adverse events, if we look at the bottom of the graph and blow it up, it looks like this. Needle-stick injuries are seen at the top line, with rates hovering about 5 in 10,000. Of course, the most common are hematomas, followed by nerve injuries, with the least common arterial punctures. As I've already mentioned, the anatomy of the antecubital space has been idealized when it comes to the instruction of healthcare providers on the insertion of a needle into this area. The superficial extremity veins are shown in this. The upper extremity veins are divided into superficial and deep venous systems. So if you look at the deep veins, the major deep veins of the upper limb include, they're located underneath the deep fascia, which means they're somewhat protected, and you would actually have to penetrate the fascia to get to those. They're paired veins that accompany and lie on either side of an artery. The brachial veins are, of course, the largest in size and situated to either side of the brachial arteries. More proximal to the brachial encephalic veins empty into the axillary vein, which connects centrally. Superficial veins. The main superficial veins of interest in the upper extremity include the cephalic, the basilic, the median cubital, and accessory cephalic veins. As you can see, this is an idealized version, and as you can see, some of the nerves are underlying the common veins that we use in penetrating veins to collect blood. And you can also see that there are nerves even overlying the basilic vein in some cases. This is reality. These photographs were taken from an article published in Transfusion in 2000 by a notable neuroanatomist, Stephen Horowitz, who carefully dissected both the left and right arms of 7 cadavers for a total of 14 dissections. He found that in 6 of 14 extremities, the major branches of cutaneous nerves were superficial to or overlying veins, and in many instances, nerves and veins were intertwined, making it, what this means is even with a clean entry, with no error in phlebotomy technique, the needle can and does come into contact with the nerves. Moving from the challenges presented by an imperfect anatomy, let's take a deeper dive into the types of serious arm injuries that can occur. These 3 broad categories include damage to nerves, inadvertent arterial puncture, and hypercoagulable states, and we'll talk about each of these in turn. Perhaps the scariest and rarest of adverse events caused by injury to a nerve is known by many names, RSD or reflex sympathetic dystrophy, but these days it's more commonly called chronic regional pain syndrome, or CRPS. By definition, is a pain syndrome with pain out of proportion to the injury. So a small needle, a small injury, and a great deal of pain. This pain is usually reported as burning in nature. To meet the criteria, the patient must have at least one symptom and one sign of each of 3 categories. Sensory, usually with increased pain sensitivity, such as allodynia, which is pain to the very light touch or the touch of a very light fabric, and also temperature sensitivity. Vasomotor changes include changes in color, such as edema, temperature asymmetry, and changes in sweat patterns, usually increase. Finally, motor or trophic changes usually appear late and include findings such as decreased range of motion and changes in hair, skin, and nail texture. Let's look at some examples. Now, you can see these are called pseudomotor, and pseudomotor changes occur early. And this is where you see edema and swelling, a great deal of swelling. And you can have either increased or decreased temperature of the skin or increased or decreased sweating. Sensory changes are also early and include, as we already discussed, allodynia, hyperpathia, where you're very hypersensitive. And finally, motor and inflammatory changes come late, and this would be increased range of motion. In terms of trophic, you see changes in nail growth, hair growth, glossy skin. And of course, anyone who would have this entity is going to be depressed and have a lot of suffering. These are examples. To the left, this is early, and you can see that the left foot is both swollen and shiny. Later on, you see changes such as the middle and right photograph, where you have hyperkeratosis, you have increased hair growth, and clubbing of the toenails. The pathogenesis is really obscure, and it makes it really, really difficult to understand. If you don't know the pathogenesis, it makes it hard to treat. It's probably sympathetic hypersensitivity after a painful stimuli, and you can see that the damaged nerve fibers generate ectopic impulses which form a loop. So you have pain in the hand, it goes up to the brain, and then a pain signal goes down the spinal cord. The sympathetic impulse triggers the inflammatory response, causing the vessels to spasm, leading to even more pain and swelling. And this this is a loop that goes. And that's why it's very difficult to intervene. There can also be released neuropeptides that cause nerve excitability, of course, inflammatory. But the bottom line is, like many, many medical entities, this is probably multifactorial. This is the natural history of progression, and I've already talked about in the acute phase, the first 2 to 3 months, it's a warm phase with swelling, redness, shininess. The second phase is dystrophic up to 9 months, and the redness now gives way to cyanosis or pallor, and you can have bone demineralization. And finally, the chronic or late stage is called atrophic. And you have cold extremities, chronic ulcers, infections, clubbing, and hourglass nails, and in this case, severe bone demineralization, and as would not be surprising, depression. Because the syndrome is believed to be perpetuated by the sympathetic nervous system, a stellate ganglion block can be both diagnostic as well as therapeutic. It can block the chronic cycle of pain and serve to confirm the diagnosis at the same time. And often treatment is with several of these serial stellate ganglion blocks. Therapeutic modes, it has to be early and vigorous treatment. This can get out of hand quickly. Obviously, a good antidepressants, gabapentin and pregabalin, even though they're anticonvulsants, work well, and also early psychiatric intervention. Other minimally invasive approaches would include, as I've already mentioned, steroids, medications, TENS units, which is neuromodulation, but it's on the outside of the body. More invasive would be the sympathetic nerve blockade, which I've already mentioned is diagnostic and therapeutic. Subepidural and intrathecal drug administration obviously is much more invasive, and neuroimplantable neuromodulation, spinal cord stimulators. Finally, there are really the surgical or experimental approaches, which are really only for very severe cases: neuroablative, chemical, or sympathetic, surgical sympathectomy, radiofrequency ablation of sympathetic ganglion, and in severe cases, it's led to amputation. But I will note, amputation really was not successful either. These people continue to have chronic pain afterwards. The association with with nerve injury and donation. The Horowitz I mentioned earlier had a report with 30 venipunctures, and only one of those was a blood donor. The rest were regular routine venipunctures. Sorensen and Voxane reported neuropathic pain from donation at a rate of approximately 5 in 100,000, leading to disablement in 2 to 3 per 100,000. And you can see some of the various manifestations: pain in the arm, diminished force of fingers. Although in Sorensen's paper, none were actually described as CRPS. And finally, Bruce Newman, which you'll hear a lot about from the American Red Cross, described about 1 disabling arm injury out of 1.5 donations. So you can see the rates are all over the place, and that's because it's not a well-defined and recognized entity. Now, there are other injuries associated with arterial puncture, notably AV fistula, pseudoaneurysm, and compartment syndrome. Let's briefly review the anatomy. Of course, veins on the bottom are very thin-walled, and they have very low pressure. Arteries, on the other hand, at the top are very thick-walled, and the contents are under high pressure. Arterial puncture rates are a little bit more knowable. Bruce Newman, as already mentioned, looked at 410,000 whole blood donations and reported 12 arterial punctures, or a rate of 2.9 per 100,000. The diagnosis is pretty clear. You can see the picture at the top. The dark blood on the right vial is venous. The bright red blood to the left is arterial blood. It also, because it's under pressure, it fills very fast. And in some cases, you can see pulsation of the tubing, though I've never really seen that myself. Some of the things that can happen: you have an abnormal vascular connection between a high pressure artery and a vein. This is called an AV fistula. They do this, of course, for dialysis on purpose. And the picture you see on the right is a dialysis AV fistula that's done on purpose. The diagnosis would be pulsing, an elongated mass that's pulsing, a thrill, which is a vibration and is palpable, a bruit, which is audible. Also distended distal veins, and it's confirmed by an angiogram. And sadly, the only thing that can be done is surgery. So you can see we're getting into some serious treatment options. In terms of reports, most of these are actually case reports because they're so rare. You can see one case from 1971 in transfusion, a brachial AV fistula successfully repaired, reported in transfusion 2000 in an abstract. That was a single case in a 26-year-old male that was surgically treated without complications. From transfusion in 2005, a single case of a 23-year-old right-handed male, 2 weeks thrill and a confirmed bruit, left brachial artery to median antecubital vein, again successfully repaired, and once again Bruce Newman, in Transfusion Medicine Reviews in 2013, described one case in 23,000, which is pretty low. And you can see the description of the case there. The second complication is pseudoaneurysm, and this is the failure of an arterial puncture to close, leaving a pulsatile mass or hematoma on top of the artery. Most commonly results from invasive procedures such as angioplasty, cardiac stenting, and arthrectomy, which use large needles, but remember, we use large needles too. The diagnosis is a firm swelling along an artery lasting several weeks to months. You can have pain due to compression of nerves. There's a thrill but no bruit or distended veins, and it's confirmed by angiogram. And you can see a picture here. To the left, you see true aneurysms, where the full thickness of the arterial wall bulges out. When the blood enters only the externity, it goes through the wall, and only the outside is ballooned out. This is a pseudoaneurysm. But it makes it very difficult to tell if you do a radiogram on this. They look identical. I won't tell you, actually I will tell you which is which. The one on the left is a pseudoaneurysm and the one on the right is a true aneurysm. In terms of case studies of pseudoaneurysm, I won't go through all of these, but you can see again, they're really mostly case reports. 1994 from Bruce Newman. We have the Indian Journal of Vascular and Endovascular Surgery in 2018. and finally Popovsky in 1994 transfusion. And as you can see, all of these were successfully repaired with no neurological sequelae, but still the donor has to undergo surgery. Here are a few more case descriptions. Again, as I said, these are really purely case descriptions because they don't happen in clusters. They're very rare. The only one who really looked at the rate would be, again, Bruce Newman. And in his reports in 1999 and also in 2013, he reported 4 cases and 9 million donations for a rate of 1.5%. In 2013, he presented a rate of 0.1 to 0.04% of arterial punctures. But if you remember, arterial punctures are not that common. Then the real rate of donations is 0.0014 to 0.0056% of all donations. Moving on to the final complication from an arterial puncture. This is really a very serious and limb it can injure the limb, and it can result in loss of limb. And it results from a rapidly expanding space occupying lesion in a closed space. And because it's a closed space, it can't expand out, so the expansion goes internal. And when it does that, it compresses nerves, arteries, and vessels. And doctors really love to use terms like, alliteration. So we have pain, pallor, pulselessness, paresthesias, and paralysis. The pain is actually due to accumulation of metabolic products because they can't go back into the system and they accumulate. Pallor, because there's a lack of blood supply, because the artery has been occluded. Pulselessness, again, due to lack of blood. Paresthesias are actually due to nerve ischemia and death. And paralysis is also due to nerve and muscle ischemia. The treatment has to be immediate recognition. You cannot delay. It can result in ischemia, gangrene, and loss of limb. Usually, a fasciotomy done within 12 hours can reduce pressure and lead to a cure. This is an example on the left. You can see, this is the leg, of course, not the arm, but you can see the nerve, vessel, and artery traveling in the bundle in the interior of this extremity. And if you have swelling, and this happens to be from an electrical injury, and all of the muscles are swelling, and you can see that now they're compressing the popliteal artery, the tibial nerve, and popliteal vein, leading to this entity. With compartment syndrome, you have to have a fasciotomy, which is a very large incision which has to go through the fascia. It does relieve the pressure on the nerve, artery, and vein. However, it leaves a very ugly scar. And I think you can understand that if a donor came in donating blood for the good of the community, an outcome like this would be very ugly, and it would be very sad because they will have, this has to heal by secondary intention. You cannot close this wound. And probably there will be skin grafting. So compartment syndrome, how often does it happen? Again, these are rare, and so you only see them really as case reports. You can see 1999. This one was very unfortunate. A fasciotomy was performed. However, the hand was infected with group-based strep, and despite multiple debridements, it resulted in left hand amputation. A very sad outcome. Once again, our friend Bruce Newman in Transfusion Medicine Reviews, I highly recommend this artery, described a 71-year-old female who had swelling of the right venipuncture site 1.5 minutes into the collection, and within 4 hours lost complete feeling in her right arm. A fasciotomy was performed with complete recovery. Finally, we're going to hit hypercoagulability, and this results in either a deep venous thrombosis, or in the worst case, you can get a pulmonary embolism. And we'll talk about how this happens. Injuries associated with hypercoagulability, we've already talked about DVTs. The cardinal signs of a DVT are pain, swelling in the extremity, edema, extended veins because they can't return flow to the upper extremity, erythema, and warmth. And you can see in the photograph to the right hand You can see it's swollen, it has edema, and distended veins. So the upper extremity DVT is not that common, but it's associated with many risk factors, such as any DVT, whether upper or lower extremity: smoking, oral contraceptive pills or hormone replacement therapy, sedentary or prolonged bed rest, or even travel. Post-operative, that's when we get people out after surgery, get them out of bed and walk them around and get them moving. Difficult or missed venipuncture. Sometimes post-donation, someone will have repetitive arm movements. They lift weights and they can get this. Really strong indicators would be family history, such as factor V Leiden, protein C, protein S, or antithrombin 3 deficiency. And then there are various prothrombin gene variants. And it's worth noting that almost all the time that you get an upper extremity DVT subsequent to phlebotomy, there's almost always a risk factor. So let's look at some of these. And again, they're very rare. From Angiology 1987, there was at 11 days post-donation, there was a thrombus. So this donor had no risk factor. The next case from transfusion in 2004 was the donor 5 days post-donation had pain and swelling. A thrombus was found on angiography. The donor was anticoagulated 6 months and had full recovery. However, the risk factor was oral contraceptive pills. Again, the only big study was by Bell in 2014, and he confirmed venous thrombosis with or without axillary vein involvement, 20 cases of upper extremity DVT in over 4 million donations over a 38-month period. Interestingly, 75% were females. And if you look at the risk factors, 10 had failed or difficult phlebotomy. We had oral contraceptive pills or HRT, factor V Leiden, and only two of those had no risk factors. Looking to the right, we have another case in 2022 of a Caucasian female, and she completed 6 months of medication. She had progressive pain and swelling in her arm, right brachial vein thrombus on duplex ultrasound, and was treated, as I said, with a pixazban for 6 months, and there were no recurrence. Any kind of risk factor was not noted in that case report. Dr. Camel from my institution reported 2 cases, one in a 41-year-old female, and there was clotting extending all the way from the elbow to the armpit, treated with anticoagulation, and the risk factor was oral contraceptive pills. A second case in a 32-year-old male had Doppler showed proximal brachial and axillary veins. The clot resolved in 3 months. And all hypercoagulation studies were normal, so no risk factor was found in that case. Again, our friend Bruce Newman described 3 cases, and if you note, they all had risk factors except one. The first case was on oral contraceptive pills and also was a heterozygote for prothrombin gene variant. The second was a 17-year-old male, and his risk factor was that he was a heterozygote for MTHFR C677R and a 4G mutation in TPA inhibitor. And finally, a 17-year-old male who had all hypercoagulation studies were negative. So, of course, we know that anytime you have a DVT, you can have a pulmonary embolism. Again, this would be much less common. Bell, in a series of upper, and we already talked about this study before. He did a study of 20 DVTs. We talked about those. Only one of those DVTs actually resulted in a pulmonary embolism, and that was a female on oral contraceptive pills, although we had no other information on that donor. There was a case reported by Adams in Archives of Surgery. I have no details on that case. And finally, Basu in Transfusion Medicine of 2015 described an 18-year-old female healthy. This is an odd story. She was riding home on her bike, I believe, after donation and became short of breath. 2 days after donation, she was seen in the ER with a VQ scan, which confirmed bilateral small PEs. She was discontinued home for 6 months. She was a non-smoker, but she was on oral contraceptive pill. So in conclusions, I know this was probably a fairly scary presentation, but the good news is very serious outcomes secondary to needle injury during blood donation are thankfully very rare. Most are reported as single case reports because they are that rare. The possible exception is DVT rate among 4 million donations in Australia, supported a rate of 1 in 211,000. And as I said, all others were provided as a case report. You know, in terms of the possibility, cases are not, the low rate could be that cases are not reported in the literature either because of severity or legal issues. And often if there is a legal issue associated with a bad outcome, it is not reported in the literature. So while blood donation is generally safe, devastating outcomes have been reported. Thank you for your attention. And if you have, I'm sorry if you have questions, I would welcome you to email them to me at drdrmary, M-A-R-Y-J-T, @gmail.com. Thank you for your attention.
Right, that's a fantastic presentation from Mary Townsend there. So we do have some time for questions, and some questions have come through the chat. So I'll welcome our speakers to be there, and I'll hopefully get through the questions as they are. And the first one, I think, most of them actually for Imad, but the first one I think was answered in his presentation. It was how can we assess imputability for such serious cardiac complications in relation to blood donation? And I think, Imad, you did give your imputability sort of clarification.
Yeah, it's very difficult to assess the imputability for cardiac adverse reaction because there is no relationship and for the causality in the literature, and it's very difficult to with the to connect with the pre-donation cardiovascular risk factors of donors, and some donors don't respect the recommendation to don't have sport, several sport after donation, and for biking and football and whatever. This is why we defined another notion of the aggravating and triggering factors of the donation for hypovolemia and whatever for the and in connected to the time of the occurrence of the adverse reaction after donation. We connect this. This is really important to say. This is certainly aggravated if the occurrence is within 12 hours. And to have the probably after 12 hours to 24 and whatever. Okay.
Right, thanks.
And it's important to have benchmarking with other countries to study the same adverse reactions.
Great. I'll skip the next question in the interest of time, because I know, Joe, you would like to respond to one of the questions. And the question is there any international benchmarking of donor complications? What are donor SAR reporting arrangements in the EU? How do the new SOHO regulations impact donor hemovigilance?
Thank you. Well, some work has been done, including by the IHN in the former ISTER database, with which we collected data from the member organizations. And indeed, annual donor SAR information is collected voluntarily, provided voluntarily by the majority of the EU member states. However, we see a roughly 100-fold range in the rates if you look at it per 100,000 donations. And so at present, we aren't capable of saying this is a benchmark. It is something we are looking at, and work is being done to look at the effects of applying the Townsend tool for severity assessment, see if this will bring the rates closer to each other, but work is in progress on that.
Great, thanks, Joe. Unfortunately, we're running close to the end of time, so I appreciate there were some more questions that came through, but we probably can't answer them now. I don't know if we have an opportunity to answer them in some other way, but because, as I say, we're running close to time, we probably should bring the session to a close. So a huge thank you to Imad, Veronica, and to Mary for 3 excellent presentations, which I very much hope you enjoyed. I must also acknowledge the excellent support provided both by Raquel Lopez and Darren Hall from SHOT, who have helped put the meeting together and looked after us today. Whilst the IHN Seminar Committee doesn't have any other webinars planned for this year, we are working towards next year's international seminar, which happens every 2 years, which will be held towards the end of the first quarter of 2026. And as Fruthi mentioned earlier, there hopefully will be more information coming out about that once we have some more details locked in. Finally, before you go, you'll just see on the screen there is a poll. So if you could please provide feedback on the meeting by completing our brief online poll, which will remain live for a couple of minutes or so. And that gives us some insight into whether you enjoyed the session, if there's anything else that you maybe would like to see from IHN seminars or webinars in the future. So please take some time to answer that. There is, or please feel free to quote this presentation as a CPD activity. I think it's 1 point, or it's worth 1 CPD point for programs. So of course you can put that in for that. So really, once again, thanks very much, and I hope very much you enjoyed the session.
Thanks, everyone.
Thanks, everyone. Thanks, Simon.
Thank you.
Thank you.
Unfortunately, Matt, there was quite a few questions for you, but we just, I think, ran out of time to go through them. And most of them were around about whether or not you give more information or consent. When you're consenting donors, do you give them the sort of the information that you have? And also around excluding donors for arrhythmias or what was the other one? Yeah, so do you accept donors with a history of arrhythmia or mild CAD? But unfortunately, I couldn't ask those because I say we ran out of time. But
I can respond by email if any.
I don't know, Shruti or Darren, Raquel, even Barbie, whether or not we access the questions and can post them online.
We should be able to access them from this because we recorded
Yeah.
it.
Yeah, we
Yeah.
can. I will
Okay.
send it to you. Yeah.
We can just post the answers online. That'd be great.
Great, thank you.